So on the Ask Me Anything panel, we'll have a clinical nurse specialist, uveitis specialist, 2 of them, both of them who look after children as well as adults. And we have also got a patient expert whose child is affected by uveitis.
Okay, so we're gonna go with the online question now. Parent asks, what do I need to consider as we start looking to a move to university? So they've been spoiled by living entirely too close to London so far. So what should they be considering for their child moving to university?
Can you hear me? Yes.
Yes.
So in general, it depends where you're going to university, whether you're going to be coming backwards and forwards to whoever's looking after your uveitis normally. So if you live in London, for example, and you're going to university somewhere else, if you're likely to spend more of your time on holiday than you are at university. So it's reasonable for your hospital appointments to be structured around the time when you're not at university, and you need to know how to seek help while you are at university. But most of your care can probably be managed within your original hospital. Or if you're at Great Ormond Street, it's slightly different, because if you're at Great Ormond Street, you stop your care here at 16, and then you'd probably move to a young adult service, and we have a young adult service at Moorfields, which is from 16 to 21. If you're in a part of the country which has sort of a more continuous service, so Sheffield, for example, has a very good uveitis service, and it's all within one building. So your care would remain at Sheffield, even though the individuals may change.
Having had a godson with ankylosing spondylitis, I know some of the difficulties he faced when he was trying to procure his prescriptions. So it's also worth considering, obviously, changing GP and obviously making sure you've got supplies of pharmaceutical products. And that obviously includes if you've got your Amgevita on contract through Sciences or Healthcare at Home, as we knew it, you would have to make sure that you had up-to-date addresses for deliveries. And then obviously there are the logistics, like having a fridge for storage, and you might be in student accommodation with a shared fridge. So there are a few kind of pharmaceutical and prescribing challenges, I think, in that.
Next one, would you introduce yourself? Everyone here knows you right now, but if you don't mind having a chance to chat with you.
Yeah, I'm Christine Toomey. I'm uveitis rheumatology nurse specialist at Great Ormond Street.
We have some in-person questions. So first one is, could some vaccinations cause autoimmune responses?
Hi, I'm Ilaria Testi. I'm working as a locum consultant at GOSH. So vaccination can induce some autoinflammatory or autoimmune response. And we saw this not only with the COVID vaccination, but there's been cases also with other vaccination like hepatitis B or influenza. We recently collected this in adults, some cases of uveitis, presumably after or post COVID-19 vaccination. We collected 70 cases from all around the world. It's not that this proves causality between the vaccination and the uveitis. It's just that basically all these episodes of new onset of uveitis or recurrence of uveitis happen within a 6 weeks from the vaccination. So this is not proven that is the vaccination that induced uveitis, but anyway, we have a temporal criteria that can support a potential association. And we have now started also collect some cases of uveitis post-COVID-19 vaccination in the pediatric population, and we have collected around 20 cases. What I just would like to stress is that in our cohort of 70 patients post-COVID-19 vaccination uveitis in adults, all the episodes were really, really mild and were basically anterior uveitis, and they got treated only with topical therapy. So there is basically no contraindication in getting the COVID-19 vaccination or other kind of vaccine just because you have a previous history of background of uveitis.
I think, and so that work was difficult to organize, and Ilaria spent a lot of time coordinating with all the professionals around the world that look after uveitis. And I have to say that 70 cases in the world is not many at all. And so that's just really important to stress that, you know, you would expect many people to get uveitis in the world, and 70 cases after a vaccine is a low number. So we really want to emphasize that our advice is to get all the vaccinations that are recommended by the government, including COVID vaccines, the polio booster, and that would very much be our party line.
Right. Another question from our viewers online. It says, do you have any tips for accessing emotional support for children with uveitis? And also any recommendations in supporting schools or teachers in understanding the condition and medication effects? Her son is in his GCSE year.
With schools, obviously my role is pivotal in crossing the school health service barrier. Teachers obviously have sometimes little knowledge, obviously, of the condition. There are a whole plethora of articles and different booklets through Versus Arthritis, which I can email or anybody can access on the Versus Arthritis website, which Lola talked about earlier. One of the other people you need to speak with at your school will be the SENCO, who is the person in charge of the children with additional needs. You will need to bring your child's condition to the attention of the SENCO. They should become your new best friend. And you should talk to them quite clearly 2 years leading up to GCSE, if you have an opportunity to, with due consideration of positioning in the class, of the whiteboard, using laptops, considering extra time. If your child also has arthritis, obviously you could consider the issue relating to hands and flexibility, because they can have rest times as well in their exams. But I stipulate that has to be 2 years before the GCSE exams. So there's no point going to see us 6 months before the GCSE and say, can we have a special letter because my child's going to be doing their exams. And this work has a long lead-in time, and the SENCO at the school, particularly at secondary school, will have a very lead role in applying for extra time for your child or for additional support in terms of laptops or rests in exams.
Hi, I'm Hayley. I'm a parent of a child with uveitis. He's only 11, but I found that with the school, you constantly need to be giving them information, because once you hand it over at the beginning of a term or something, they tend to forget. And if your child's not flaring, they're not really remembering that they're still having injections or tablets or anything, and it's ongoing. So, and you know how your child is. Sometimes more, they have a really bad headache, and the school, I mean, if you've got a great SEN team, then they're absolutely brilliant and they will understand. But I just found, for me, constantly send them information. Lola was amazing at sending me information that I could pass on to them, so that they would understand that your child, even though they might not actually be in a flare at the time, there's still so much going on with them through the weeks and the months and the years.
So just before we move on, I think we didn't fully answer the question about how to access psychosocial support, because we focused on exams and stuff. Could you just elaborate on that? Strawberries, it distracted us. Did you do psychosocial?
Oh, that's quite a long story, Lola, isn't it? We've been talking recently, obviously, since lockdown and the pandemic, and obviously recognise that many of our families, parents and the children and young people, are obviously suffering quite a few difficulties due to that dreadful experience we've all had. So we've been looking at how we can best support some of our families, and we're returning in many ways to a scene that I knew probably 10 or 15 years ago in nursing, where we spent much more time with play therapy with children, like the younger children, and thinking about procedures that they may begin to undergo with us. So Lola and I are committed. We've met with the play specialist and we've started talking to them about how we can anticipate the children on our list to start thinking about the painful interventions they may undergo, and how we could do some age-appropriate work with those children before they get to the stage of the clinic, the intervention, the photograph, or the dummy pen. And I think we've all learned a lot through the reintroduction of the play specialist into the medical scenario. Great Ormond Street was very good at that when I first started here in 1985. Unfortunately, it seems to have, I won't say fallen by the wayside, but I'm sure cost cuts have probably added to that, unfortunately. But we always must remember the value of play and how important it is in a child's life at each age year through their age span through to adolescence. And with our adolescent young people, we've also recognised some self-harming and other unfortunate kind of feelings they've had. And we're starting to think about how we can support them much more. Lola has talked, and Harry and I and Ilaria, to our psychology team about us using appropriate terminology and how we can use appropriate interventions that we can access through our own team here at Great Ormond Street. Lola, is there anything more to say? I'm sure you can say more.
So that was a fab answer. That was a very GOSH-specific answer. And that same lesson should be applied to wherever you're being looked after. So it's always the safety belt approach. People tend to think that they're always going to be okay. And then when they're not, you're in such a state that it can be a real burden to find the support that you need. So everyone in this room should have or should ask their ophthalmology and rheumatology teams 2 questions. If there was a mental health crisis, what's your advice? And they'll be able to direct you to the pathway. It's normally through your GP, actually, or through A&E in real crisis. And what's available at this hospital for supporting children who might be getting there, on the way there, or just as a preventative step. So what's available for me within your local hospital? And can you just talk me through the pathway in the community for getting emergency help? Because you always think it's not going to happen to you until it does. It's sort of like the seatbelt approach to care. But as Christine was saying, it's really important to take those preventative steps to foresee where there might be this burden. Everyone who has a child or is a child diagnosed with a chronic disease automatically has a risk factor for psychosocial concerns, automatically. It's just one of those things that should be taken as granted. Very good chance that you'll come through it okay, but there's also the possibility that you won't. So it's all about making sure you identify where the support is around you. So as well as those hospital-specific pathways, there are a few things that if you don't know about, you should know about. So Olivia's Vision, I don't know if people online can hear me. So Olivia's Vision is a uveitis specific patient group. It's charity-based. They can sometimes struggle to get funding, but they make the little pots of money they have go really far. So they're available for giving you extra additional support when needed. Juvenile arthritis research and children with arthritis, although arthritis is in the title for both of them, because in uveitis, we get seen by some of the same teams, we use some of the same medications, we share nurses, we share structures. They are very well versed in supporting children who only have uveitis. We'll put all these into a little end of day info pack that we send out to everyone. Alderhay Hospital also have this amazing website they developed with their local team. So you'll have to ignore this bit, make a referral unless you live in Liverpool or the Alderhay region. But they've got these fantastic packs research-wise, so videos to watch, things to download for people who either have a diagnosis for their mental health challenge, or where it's something that's broader, like loneliness, for example, or isolation or panic. Really good videos and resources for supporting you. And again, we'll put that in the pack to send around. So they developed this through Alderhay Hospital in association with the Childhood and Adolescent Mental Health Service. There's a growing understanding that the mental health service in the UK, the waiting list is already 2 years. It's only going to grow post-COVID. So the key is about early intervention, identifying the risk factors. Even though most in this room are going to be completely fine, it's the seatbelt approach. It's the seatbelt approach. Make sure you know where the support is around you. And that goes for the people online as well. Okay.
And we have another one. She says, my daughter, age 10, has had MTX and adalimumab injections for 2.5 years. Every week she asks, can't I have my medicine in my strawberry? She hates injections and wants someone to invent a way for small children to take the medicine without injections. Is this viable in the future?
Well, I mean, there are some kind of medication that are taken in different form, from injection or infusion. We have syrup, we have a liquid solution, we have tablets. I think it is depend on basically the medication itself. There are different ways to administer that. There are some medication that can administer only via injection or infusion, and other medication. For example, we have the methotrexate, we have the tablets, we have the injection. Mycophenolate, we have the tablets, we have the oral solution. So I think it's depending on the kind of medication. I don't know if it's in the future they will be able to find a different way to deliver, for example, adalimumab, but also, I mean, the injection and the infusion way sometimes are more efficient way for absorption and also for the efficacy of the medication itself.
It also depends what's wrong. So if it's just your eyes, then, as I said earlier, so mycophenolate is more of an option. But methotrexate works better as an injection, particularly at bigger doses. When you're little, it's not such an issue, but when you're bigger, the injection just is absorbed better and it works better. And as far as that level of care, I don't know if you remember on that pyramid goes, methotrexate really is the thing that's going to work for the joints. It's one of the reasons why it's so important to engage with clinical trials, because all of the newer medications, a lot of the newer medications coming out are oral. And the more oral medications we get on our books, the more that are proved to work, the less injections people will need to have. So it really will, I think, change therapy.
We just mentioned the strawberry part of the question. I think it's a great temptation for any parent with any medication to disguise it in a strawberry, a banana, a milkshake, chocolate, or whatever they choose. But I think a pharmacist may have something to say about the pharmacokinetics and actually how that medicine works when it's been disguised in an acid fruit. Parents also suggest that they have ways and means of giving injections of methotrexate, particularly surprise injections in the night when the children are asleep. And clearly, this is not the way to go. And probably for the future, you can't do that when they're a teenager. So yeah, there's always thinking about the long term and the planning about how you're going to manage this over the lifespan of your child whilst they're at home with you until they reach independence, when they can start giving it themselves.
One question we have now, is it common for side effects to get worse the longer you are on the treatment? This is someone in the audience here today.
Well, I think side effects are not related actually to the length of treatment. There are some patients who experience side effects immediately after starting a medication. And so this means that the medication is not the right one for them. And so we are going to try to switch to other option. And there are patients who actually develop the side effect after a long time that they have been on a treatment. So it's not actually related to the length of the treatment. Obviously, there are some side effects like allergic reaction that might develop soon after start the treatment, and then you have to stop the drug. But I mean, other side effects that can just develop after a few months or even year that you are taking the drug.
I think methotrexate, I don't know if the question was specifically regarding methotrexate. Yeah, so it's different to the other medicines. And so there is something about methotrexate, as amazing as it is, and I will repeatedly say methotrexate has literally transformed patients' lives. And if you speak to, I'm sorry to repeat myself, but if you speak to the people who trained us, so sort of 2 generations back, they would say that the hardest thing about getting to our clinic rooms at Great Ormond Street was getting past all the guide dogs and the white sticks. And there are no guide dogs and no white sticks anymore, and that is mostly due to methotrexate. And so it is a completely amazing drug, but it is also a drug which makes loads of people really unwell and loads of people nauseous, and people don't like it. And it's our job now to be able to support you through that process and away from that drug if it's not the drug for you. And again, historically, we just had to deal with it because it was the only drug we had. Some people when they start on methotrexate, are fine, and they're fine for the first few weeks, first few months, and then at some point, they start getting really sick and really nauseous from it. And in some people, that happens a decade after they've been taking it, and some people, it happens a few months after they've been taking it. And I think my message really is that just communicate it to us so that we can help you. And if it's the wrong medication for your child, then we'll do something about it. We're not going to force you to stay on the medicine. And that's, we're never going to force you to do anything. It's really about giving you the options. But we would very much recognize that pattern if that's what you're experiencing.
Okay, next question. I think this is from a child. It said, how come I see different colors in both eyes? Or they see colors differently in both eyes?
So the question is how you can see different kind of colors.
Yeah,
okay. So, I mean, there are different diseases that can be associated to this. For example, if there is a disease involvement, for example, of the optic nerve, which is a part of the posterior segment of the eye, this can cause an alteration in how you see a color. And if you look through one eye and then you close that eye and you look the same color with the other eye, this can appear different. So there are some disease and some condition that can be associated with this, basically. I don't know if you want to add anything else.
So it's very unusual for people's uveitis to be exactly the same in both eyes. It's some people just have it in one eye, and some people have it in both eyes, but asymmetrically. And so, as Ilaria was saying, if you've got really bad inflammation in one eye that's affects your optic nerve, that's one reason. If you've got macular edema, which is another, some of the pictures on the OCTs where it looks more like a volcano than a dip, that reduces your vision, but will also change your perception of color. If you've had bad swelling in the past at the back of the eye, and you've now got better, and even though you see the same line on the eye chart, it's possible that you'll perceive color slightly differently, just because of changes to the cells at the back of the eye that's been badly damaged in the past. Doesn't mean that actually your vision may be good, but color is a particularly sensitive thing to perceive, whereas the lines you see on the eye chart is actually a much cruder measurement.
Lily's just said that when she was having the cyclopentolate dropped because her eye was dilated, that took in more light, obviously. So then at that time, she was seeing colours differently. So that's another temporary difference, maybe.
That previous question, sorry, I'm sure you were going to say, Harry, but it's really important that if you are experiencing an eye symptom like that, you talk to the doctor who looks after you. Because as you've heard, there are so many reasons as to why one eye might look different from the other eye. It's like asking, why does my arm hurt? Yeah, make sure you communicate it with the doctor who's looking after your eyes so they can find out if there's something that needs to be done about the fact that you can see different colours in each eye, because there are so many causes, and sometimes it's nothing, but sometimes it's something that needs to be dealt with.
The question is, how do you know when it is safe to take patients off all medication?
So we actually do not know 100%, obviously, that it's safe to stop the medication. What we usually try to do is to evaluate the different cases. And usually we wait for at least 2 years of quiescence of the disease before starting tapering down and stop the medication. Oh yeah, sorry. At least 2 years when the uveitis or the arthritis is not active. So we basically have seen that after 2 years of inactivity of the disease, it might be safer to start to tapering down the medication. But obviously, we don't know what is going to happen. So with the methotrexate, usually we start tapering down by 2.5 milligram every 3 months. And we assess, obviously, the patient every 3 months to make sure that the uveitis is not coming back. With the adalimumab, we might just stop the medication, or we might increase the interval from 2 weeks to 3 weeks, and then again assess the kids just to make sure that nothing is happening. There are cases that with a couple of years of treatment and of inactivity are doing fine. And this means the medication were basically able to control and modulate the immune system In other cases, we noted that after stopping the medication, the uveitis or the arthritis flare up again. And this basically tells us that that patient, unfortunately, will need to stay on therapy for longer time, basically. So what we usually try to do is after 2 years that everything is fine, no uveitis and no joint, we discuss also with the rheumatology and we usually start tapering down, basically.